Okay. Right, so good afternoon. My name is Naomi, and I'm going to be talking to you about preterm birth today. My colleague, Dr. Jenny Carter, can't be here today, so I'm talking on behalf of both of us. So last year I finished my PhD, which was funded by the National Institute for Health Research, and it was called the impart study. And the impart study was looking at implementation of the preterm birth surveillance pathway. And you're probably thinking, what is the preterm birth surveillance pathway? So the preterm birth surveillance pathway was first mentioned by NHS England in 2019 in their Saving Babies' Lives Care Bundle version 2 document. And in this document, they added a fifth element, which was all about reducing preterm births. And what it basically asked was that every single woman at their booking appointment would be risk assessed by their midwife. And if that woman was determined to be at either high or intermediate risk of preterm birth, that should then be referred on to a preterm birth surveillance clinic. And a preterm birth surveillance clinic is like an antenatal clinic which women at a high risk of preterm birth would go to, and they would have additional tests such as cervical length screening done with a transvaginal scan and swab tests done, and if they're then determined to be at risk of having their baby early, they could then be offered a cerclage or a stitch or pessaries or be admitted as an inpatient if that was deemed necessary. And this is an NHS England document, obviously, but we know that there are preterm birth clinics across the whole of the UK and also in the Republic of Ireland. And this document was part of a larger sort of government response to try and reduce that preterm birth rate from 8% in England, where it currently is, to 6% by 2025. And the House of Lords report on preterm birth, which was published a few months ago, has confirmed that, of course, we're not going to meet that target, unfortunately, of reducing it to 6%. But it does just show that there is a wide sort of governmental response to try and reduce preterm birth rates at the moment in England. So this is the recommended list of referral criteria which was included in that Saving Babies' Lives document. And some of them you might be familiar with. So, for example, if a woman has a previous preterm birth, it kind of makes sense that then she's more likely to have a preterm birth in that next pregnancy. But some of them you might be less familiar with. So, for example, previous delivery by caesarean section at full dilatation. So we know that before this guidance was published, there were only about 33 preterm birth clinics across the whole of the UK, and that's out of around about 187 hospitals that are offering obstetric-led care. So we know that this was going to be a massive change for hospitals who are suddenly all going to have to implement a preterm birth surveillance clinic, having not had one in place previously. It was included in the NHS Standard Contract for 2019, which meant that if you're providing NHS care in England, you were then expected to have this service up and running. We also know that what works for one hospital is not necessarily going to be the same as what works for another. So if we think about what Mary was saying this morning about different contexts and different hospitals, what works in a large tertiary unit is going to be completely different to what works in a small district general unit. And in that sense, you're kind of comparing apples and oranges. So I really wanted to undertake a methodology which kind of understood these differences between these different hospital sites, focusing on what works for whom. So I decided to take a methodology called a realist evaluation, which really is suited to sort of gaining insight into complex interventions in different contexts. So I'm not going to spend too long talking about the methodology, but I just wanted to put this slide up here, just explaining the study design, because some of you might not be familiar with it. So just to go through it very, very briefly, as you can see, there are different stages involved in a realist evaluation. That first stage, as you can see on the slide, involved a scope of the literature, interviews with people who developed that Saving Babies' Lives Care Bundle, and also a national questionnaire. So a questionnaire was sent to all of the different hospitals in England to see what they were currently doing in terms of preterm birth care. And using all of that information, I developed what are called programme theories, so kind of hunches and ideas about how could we implement this successfully. I then went into 3 different hospital sites in England and collected in-depth data from them, and I used that data to interrogate and refine those sort of programme theories that I'd developed before. So what I'd thought about before, was that right, was it wrong, did it need refining? And then I came up with recommendations about how we could improve implementation of this pathway throughout England. So again, as I said, it kind of involved various methods of data collection, which are outlined on this slide, and that in-depth analysis at the 3 different hospital trusts, as you can see on the right-hand side, involved interviews with women, interviews with staff, ethnographic observations, so observing their hospital appointments, and also reviewing the guidance in those 3 units. And this slide here is just showing the 3 different sites, and as you can see, they vary quite a lot. So site A was a really well-established tertiary unit. It ran 2 preterm birth clinics a week across their trust. Site B was a very new clinic which had been set up in response to this NHS document, and Site C was a very small site, had 1,500 deliveries per year. They didn't actually have a preterm birth clinic, they just saw women ad hoc when required in their antenatal clinic with a named consultant, and they didn't have any access to the preterm birth screening tests which are available. So I'm not going to spend any longer talking about the background, but if you did want to know more, these QR codes take you firstly to the publication of the main results, the top one, and then that bottom one takes you to an NIHR alert on the study, which was published last month, and that's a kind of lay summary of the impart study as well. So onto the results. We found 3 explanatory areas. So the first explanatory area deals with problems in correct risk assessment and referral to a preterm birth surveillance clinic. The second explanatory area in green looks at how once a correct referral has been made, how knowledgeable and supported clinicians deliver a well-functioning clinic. And that third explanatory area in purple concentrates on how ensuring that pathway delivers appropriate care to the intended users it's trying to reach. So here it's women at risk of preterm birth. So what we found is that staff sometimes lacked knowledge about risk factors and why certain risk factors could make women at high risk of preterm birth. So referrals were often double-checked by senior staff, wasting time and effort and undermining the junior members of staff. We also found that practical issues such as outdated computer systems prevented or slowed down risk assessments and referrals. I've included some quotes from this first explanatory area as I think they really do highlight the issue. This study found that risk assessment and referral could be undertaken incorrectly due to a lack of knowledge about preterm birth risk factors. Across all of the 3 sites, a lack of knowledge on risk factors was noted by midwives themselves, by other clinicians, and by the woman. Even if midwives knew what tick box risk factors required referral, they didn't always know or understand the etiology behind why they required referral. So for example, that first quote really sums it up. She might know that a fully dilated cesarean section makes that woman at intermediate risk of preterm birth, but she doesn't know why it makes that woman at intermediate risk. So while the focus on this study was on midwives, because midwives are the ones who are doing those booking appointments and midwives are the ones who are risk assessing women at each appointment, we did find that this lack of knowledge extended to other members of the team, including junior obstetricians too. Even if there is a knowledge on the risk factors, a lack of knowledge on the purpose of the pathway can also result in an incorrect referral. So rather than staff simply being aware of what preterm birth risk factors were, they also required an understanding of preterm birth pathology to understand why particular care was offered at certain timeframes. So if we go back to that example about fully dilated cesarean section, a midwife referring that woman needs to know, does that woman need an appointment at 18 weeks or does she need an appointment at 25 weeks? Because that's going to determine her plan of care and then ultimately the outcome of that pregnancy. So what do we recommend? We recommend improved training and education on early birth for everyone, both midwives and obstetricians. This does not mean that everyone needs to be an expert. Myself and Dr. Jenny Carter, who can't be here today, have just written the first textbook on preterm birth for midwives after realising that there is currently no book for midwives on preterm birth. I'll talk more about this on the next slide. Education and training also involves mandatory training, which needs to be regularly offered as staff move and new staff join the unit. We need to accept that not all staff have had training on this before. Saving Babies' Lives Care Bundle is relatively new in England. If we focus on midwives again, we know that not all midwives in England have had gynae nursing experience. Myself, I'm not a nurse, I'm just a direct entry midwife, and therefore they might therefore not know what these different gynae risk factors are, for example, what a LETS procedure is. We also need to make sure that there is sufficient training for undergraduates on preterm birth, and this extends to both medical and midwifery undergraduates. We also recommend removing barriers for assessment. So, for example, through adding checklists to the computer system, so it's ingrained in that system as you're doing that booking appointment. Community midwives who are undertaking booking appointments are time poor and they're juggling a lot of referrals for a lot of different things. If we can streamline this process for them, then risk assessing and appropriate referral is more likely to be successful. But this is going to be slightly different for every unit depending on what system that they use. We also recommend prompts for staff, such as via posters and email reminders, and I know B in the previous session was talking about this in terms of OAC. And this is to continually refresh people's memories so that when they're busy and juggling clinical needs, it's at the top of their agenda. We'd also recommend a culture of openness and learning, and this is best created by the senior staff and enables staff to both ask for help and to know who to ask for help when they want advice. As I mentioned earlier, we're not expecting everyone to be an expert in preterm birth, but they should know who is the expert and be able to ask them if they want advice in a certain area. So this slide here is about the book that myself and Jenny have just written on preterm birth. You can get 20% off using that discount code on the slide, and the QR code takes you directly to the publisher's website to use it, and it's about £35 or about €30. So going back to the rest of the results from the impart study, focusing on that second explanatory area, which was the one in green, this is all about the preterm birth surveillance clinic. And what we found here is that in units with a named preterm obstetrician and a named preterm midwife with specialist skills delivered effective care compared to sites where they did not have this multidisciplinary team with this specialist concentrated knowledge. Including a named midwife in the preterm birth team was outlined in the updated Saving Babies' Lives Care Bundle version 3 document. So what this tells us is that midwives' role in the area of preterm birth is here to stay. In units with a specialist multidisciplinary team, staff trusted each other, skills were passed on, and variation of care was reduced. When only a single or limited staff member had specialist training, such as transvaginal ultrasound scanning, units struggled, not only when that person was absent, but also in terms of passing on skills to the next generation and devising care management plans. So what do we recommend? We recommend that units audit their practice, so know your individual unit, what woman you care for and what your outcomes are. We recommend that units hold regular team meetings to discuss the care of women with complex needs. We're really good at doing this in other areas, such as CTG meetings, but as preterm birth teams and care become more multidisciplinary, this is vital. We also recommend that teams and units are supported by their local networks, and this is especially helpful for the smaller sites with large tertiary units can offer their help. This can aid sharing of resources, such as guidelines, but can also help with clinicians who can then shadow in larger tertiary units to develop skills in cyclages, scanning, and/or decision-making. It also ensures that they have a network who they can get advice on for individual cases. We also recommend that all sites in the same area hold clinics on the same day. It sounds a bit basic, but if you know that you can ring someone who's also sitting in their own preterm birth clinic, they're more likely to pick up the phone and you're more likely to get that advice that you need. We also recommend that clinical staff flag issues to managers to speed up quicker resolution. In a stretched NHS, this can sometimes feel a little bit pointless, and I'm sure you have similar issues here in Ireland, but if they don't know of issues, then they can't help. Hospital managers, we'd recommend that they can improve hospital and clinic environments to ensure that the necessary equipment is on hand. So, for example, back when sites were still using fetal fibronectin, ensuring that machine is near the preterm birth clinic space. We also recommend that managers ensure necessary training is provided, for example, in transvaginal ultrasound scanning skills, and that staff have the protected time to attend this training. Training midwives to undertake transvaginal scans to measure cervical length is a great resource, especially in smaller units where their preterm birth team might only consist of one obstetrician and one midwife. There's quite a few midwives in England now who are undertaking the transvaginal scans in preterm birth clinics, and this is really exciting to see how this role is developing. So moving on to the final and third explanatory area, we found that women were reassured by continuity of care and seeing professionals who were aware of their medical history. Attending to routine aspects of pregnancy, such as birth plans, what exercise they can and cannot do, and antenatal classes, helped women not feel defined by their high-risk status. Focusing on what women can do instead of what women cannot do, and asking about their preferences for birth really helped women feel in control. So what do we recommend? We suggest greater continuity of care, and again, I know we spoke a lot about this morning. Leeds in England is doing fantastic work here with their preterm birth midwives, providing continuity right through to the postnatal period. However, even in units where this is not feasible, women could have the contact details for a preterm birth member of staff, so that then if they have a preterm birth question, rather than having to wait until the next appointment for that specialist information, they could contact someone in between to answer their queries. Some sites have worked hard at providing peer support, for example, with specialist antenatal clinics just for women who are at risk of preterm birth. But other options include clinicians being able to signpost women to find support, so for example through Facebook groups such as the TAC support group or relevant charities such as Tommy's. Finally, we recommend that hospital managers ask women and staff for feedback on the pathway and be ready to adapt the service. If the service doesn't work in the eyes of the woman, then it's not much use. I hope this presentation has demonstrated that midwives are key in this pathway and really have a role in the future of preterm birth care. This is from correctly risk assessing women at the booking appointment to the skills that they can provide in a preterm birth surveillance clinic, for example with transvaginal scanning, and providing woman-centred care. Through improving midwives' knowledge of preterm birth, we can fully release the potential of midwives in this area. Thank you so much for listening, and I'm happy to take any questions.